Diabetic peripheral neuropathy, DPN. We require to have a deep understanding about this because it is a very common condition. Diabetic neuropathy is a group of clinically heterogeneous type of presentations. It's a clinically heterogeneous peripheral nerve disorders caused by chronic hyperglycemia and metabolic microvascular injury in diabetes mellitus. It's not one entity. What you have to understand is diabetic neuropathy is not one entity. It is a heterogeneous peripheral nerve damage due to various pathological changes involving hyperglycemia and metabolic changes and microvascular injury. The commonest cause of peripheral neuropathy in the whole world is, of course, diabetic neuropathy. The major cause of morbidity, foot ulcers, amputations, and autonomic failure is diabetic neuropathy. Epidemiology is important. Occurs in about 50% of long-standing diabetics, can occur in type 1 diabetes and also type 2 diabetes. Often by the time you diagnose type 2 diabetes, already some amount of peripheral neuropathy is already set in. Between the two, in which it is more common, in type 1 or type 2? Type 1. Type 2 is more common, but neuropathy is more common in type 1. Okay. Type 2, of course, is the disease-wise, 80-90% of the diabetics are type 2 only. Only 10% are less than that is type 1. But the neuropathy occurs early because of the severe hyperglycemia in type 1 diabetes. So, the major contributor to foot ulcers, falls because of lack of sensation, cardiac autonomic mortality, sudden cardiac death can occur, and erectile dysfunction is a very important parameter of diabetic neuropathy. So, foot ulcers due to insensate feet. Insensate means lack of sensation in the feet. They develop trophic foot ulcers. Because of chronic small injury to the skin, no sensation is felt. The foot ulcers are come. Because they do not know where they are putting their feet, there will be falls. And then autonomic neuropathy of cardiac origin produces cardiac mortality and sudden cardiac death. What is that sound?
Fire.
Okay. Some fire is going on?
Yes.
Okay. Erectile dysfunction. Pathogenesis. Why this neuropathy occurs? Diabetic neuropathy is multifactorial, involving metabolic, vascular, inflammatory, and oxidative mechanisms. What are all the four mechanisms? Metabolic, vascular, inflammatory, and oxidative. Let us look at each one of them. First, the metabolic part. Hyperglycemia-driven metabolic injury. The polyol pathway. What is polyol pathway? Excess glucose is converted into sorbitol via aldose reductase enzyme. Enzyme aldose reductase converts glucose to sorbitol. This sorbitol accumulates and it is an osmotic substance. It produces osmotic stress. There will be decrease in the myoinositol with impaired K-ATP transferase. This is called the polyol path abnormality. This you have to know. Diabetic neuropathy can be an essay question. What is the pathogenesis of diabetic neuropathy? Diabetes means a lot of sugar is there, so it produces not like that. That is layman's understanding. As a technical person, you have to understand there is a metabolic, vascular, inflammatory, oxidative. Four components are there. The metabolic component is the polyol. There are 2-3 metabolic abnormalities. One is the polyol pathway. Excess glucose produces sorbitol. Sorbitol accumulation produces osmotic stress. That results in decrease in the myoinositol. That impairs the sodium K-ATPase channels. Okay. Next, advanced glycation and products. What is advanced glycation? Excess glucose tags onto the proteins. And proteins are glycated. They become glycated proteins, glycoproteins. Okay, like HbA1c is a glycoprotein. Like other cellular membrane proteins, if they are glycated, what will happen? Glycated proteins will produce axonal dysfunction. Glycation of the proteins produces axonal dysfunction. Interaction with RAGE inhibitors. What is RAGE receptor? Receptors of the advanced glycation end product. RAGE receptors are receptors of advanced glycation end products, and that results in inflammatory reaction. Number 3 is the oxidative stress. That is mitochondrial dysfunction, free radical mediated axonal injury. So, what is the basis of diabetic neuropathy? Diabetic neuropathy has got the pathogenesis of diabetic neuropathy, hyperglycemia driven metabolic injury, that is metabolic, vascular, inflammatory, oxidative. We are considering the hyperglycemia part. Under the hyperglycemia, we have got the polyol pathway activation, and the second one, of course, is the advanced glycation end products, and the third one is the oxidative stress. Then microvascular ischemia. Microvascular ischemia means thickening of the endoneural capillary basement membrane. The nerves are supplied by vasa nervorum. Vasa nervorum are the blood vessels which supply the nerves. And this vasa nervorum, there is an endoneural capillary basement is there. That basement is thickened. Once it is thickened, reduce nitric oxide penetration and endoneural hypoxia will occur and preferential injury of the long axon fibers. If the long tract fibers are affected, what is called the Diabetic neuropathy or length-dependent neuropathy will occur. The first one is the metabolic, the second one is the vascular, and the third one is the inflammatory and immune components. Low-grade inflammation, cytokine-mediated neuronal injury, more relevant in acute diabetic nephropathic syndromes, inflammatory and immune components. Okay, these are the three major ways it can cause. What are the three major pathological changes? As we have seen, the first one is the metabolic, vascular, and inflammatory stress. Metabolic, vascular, inflammatory, and oxidative mechanisms. Now, this is the pathogenesis. Now, what I told you, diabetic neuropathy is not one disease. It is a mixed disorder, heterogeneous disorder. And what are the major clinical types of diabetic neuropathy? Number 1, DSPN, distal symmetric polyneuropathy. Okay, the name itself is indicating it is distal, it is in the peripheral parts of the body, glove and stocking, it is symmetric, it is both sides, it is polyneuro, not one nerve, all the nerves of that area are affected. It's a distal symmetric polyneuropathy. DSPN. DPN, diabetic polyneuropathy, has got one subentity is called the DSPN. Most common is 70% of the diabetic neuropathy is DSPN. What is the pattern? It is length-dependent fibers. Stocking, glove type of distribution. Last time we have seen what is the mechanism of glove and stocking. Now, glove and stocking distribution. Clinical features are burning pain will be there, tingling will be there, numbness will be there. That means there could be positive sensory symptoms or there could be negative sensory symptoms also. Numbness is a negative symptom, burning pain and tingling are positive symptoms. And patients will complain the neuropathy is worse at night. If you ask him, sir, I'm not able to sleep in the night, lot of burning, lot of tingling in the night, daytime it's somewhat okay. But nighttime worsening, very important. The most important feature of this is loss of vibration. Whenever length-dependent fibers are affected, it is loss of vibration will be the first manifestation. And also because the proprioception is affected, the reflexes, particularly DTR, are reduced or absent. Later motor weakness of the intrinsic foot muscles. What fiber is involved? Early small fibers, later small fibers. What will be the complications? Painless foot ulcers, Charcot joints, and great gait instability. Now you repeat this particular thing. Memorize that one. Distal symmetric polyneuropathy. It's the commonest form of diabetic neuropathy. 70% of the patients of diabetic neuropathy are distal symmetric polyneuropathy. It depends upon the longer the axon, the more will be the effect. That is why it is peripheral. Peripheral axons are very long, so that's why length dependent. glove and stocking type of distribution will be there, and there will be positive sensory symptoms as well as the negative sensory symptoms. Burning pain, tingling, numbness in the feet, and this is worse at night. The vibration sense is first lost, reflexes are lost, lower motor type of weakness in the intrinsic foot muscles can occur at a later stage. Early, the small fibers are affected. Later, the large fibers are affected. What are the complications? Painless foot ulcers, Charcot's joints, and gait instability are the three important complications that can occur. Okay. Second, diabetic autonomic neuropathy, DAN. DAN. DAN is diabetic autonomic neuropathy. Earlier one was diabetic peripheral sensory neuropathy, DSPN, diabetic sensory peripheral neuropathy. This is autonomic neuropathy, underdiagnosed, but prognostically very severe. Out of all the neuropathies, diabetic autonomic neuropathy is not generally elicited by the physicians. They may not know how to examine for that also, but it is prognostically very severe. What are the things? Resting tachycardia. So, if a diabetic patient at rest has got 100 or above pulse rate at rest, you must consider diabetic autonomic neuropathy and evaluate for that. Diabetic should not have heart rate more than 100, just like any other person. If he has got tachycardia, resting tachycardia, you must consider autonomic neuropathy and then postural hypotension without dehydration. There will be postural hypotension without there being any reason for dehydration. These people will have silent myocardial ischemia, and they may not present with the classical myocardial pain when they have ischemia. Instead, they will have angina equivalent. What is angina equivalent?
Breathlessness. Instead of pain, breathless patient.
Yes, patient will have breathlessness, patient will have fatigue, patient will not be able to walk faster, but there won't be a typical pain of the mind. This is called angina equivalent and increased sudden cardiac death. These are the cardiovascular complications. Similar effect on the gastrointestinal tract, gastroparesis. How does the patient say gastroparesis? Constipation is one thing, gastroparesis, not intestinal paresis. Fullness. So he eats little, still the stomach is full. The contents in the stomach are not emptied down. So he feels full even after 3 or 4 hours after the meal. Star, after 4 hours also I still feel fullness. After 2 hours you feel like going to the canteen again because the food is emptied. These people will have gastroparesis and vomiting may be there, belching may be there, and then they will have because of gastroparesis, they will have acid eructations. Because acid is stagnating in the stomach for a longer time, acid eructations, vomiting, nausea, abdominal distension, fullness in the stomach, even after 4 or 5 hours after eating, are the symptoms of gastroparesis. They may have diarrhea or constipation and fecal incontinence. This also you have to understand. Patients will complain, sir, I am okay, but what is happening sir? In my pant, I am just passing small quantities of motion without my knowledge. This is fecal incontinence. So immediately you should think in a diabetic patient. Gastrointestinal autonomic neuropathy. Genitourinary erectile, I have diagnosed n number of patients of diabetes just by erectile dysfunction. Patient comes for erectile dysfunction, evaluate, he is a diabetic. Erectile dysfunction is endothelial dysfunction. It is a direct indicator of poor diabetic control. Neurogenic bladder. So this is also very important, and retrograde ejaculation can also occur in case of genitourinary. So DAN has got 3 components. Component 1, that is cardiovascular, tachycardia, postural resting tachycardia, postural hypotension, and then silent myocardial ischemia, increased sudden cardiac death, gastrointestinal, gastroparesis, diarrhea, constipation, fecal incontinence, genitourinary, erectile dysfunction, neurogenic bladder, and then retrograde ejaculation. Diabetic neuropathy, the autonomic neuropathy is a severe form of dangerous neuropathy. Then there is another thing called the pseudomotor. This one, that is, he will have anhydrosis, no sweating in the feet. There will be hyperhidrosis in the trunk. So very typically the patient comes, sir, my feet are very dry, but all over my chest and body I am feeling lot of sweating. This is called the pseudomotor autonomic instability. This cardiac autonomic neuropathy signifies very poor prognosis in a patient of diabetes. Now, what are the two things we have seen? Diabetic neuropathy classified into diabetic symmetric sensory polyneuropathy, peripheral neuropathy, symmetric sensory peripheral neuropathy. Second one is the autonomic neuropathy. The reasons are the metabolic, vascular, inflammatory. These are the various ways of pathological processes. Then amyotrophy. This is rather rare, but diabetic amyotrophy, that means muscle wasting. Where the wasting will be there? Lumbosacral radiculoplexoneuropathy. Lumbosacral radicals and plexus are affected, and there will be wasting of the thigh muscles, wasting of the hamstrings, wasting of the quadriceps, and all these things. A distinct entity, it is not length dependent, and it will be proximal neuropathy. So the type of neuropathy that you see in amyotrophy is proximal weakness, not distal weakness. Whereas in case of long-standing peripheral neuropathy, you may have distal muscle weakness. That is a long-standing peripheral neuropathy of the sensory type. Here, if somebody has got no sensory symptoms, he comes with amyotrophy, wasting, weight loss, asymmetric, proximal weakness, severe thigh and hip pain may be there, may be acute and may be chronic. What is the pathogenesis? Vasculitis of the lumbosacral plexus. I told you the vasa nervorum of the plexus is affected, the endothelium is thick, the basement membrane is thickened, nitric oxide cannot enter inside, there will be oxidative damage, and microvasculitis will be there. The clinical part, if somebody who is long-standing diabetic presents with painful proximal weakness is amyotrophy. Usually, any amyotrophy of the spinal origin is not painful. Here, this fellow has got amyotrophy with pain. Pain because of the sensory involvement, amyotrophy because of the muscle wasting. There will be wasting, areflexia, and then proximal muscle weakness. If you have in a diabetic patient with peripheral nerve involvement and pain, it is diabetic amyotrophy. Then, what are this is the fourth one we have. Now we have got focal and multifocal neuropathies. What are the things we have seen? So diabetic amyotrophy we have seen, DAN we have seen, and then these three are diabetic neuropathies. What? Diabetic autonomic neuropathy, and then first one is the peripheral sensory autonomic neuropathy. First one is the DSPN. The DSPN, distal symmetric polyneuropathy, or DSPN. The fourth entity is the types of the neuropathies, out of which distal symmetric polyneuropathy, autonomic neuropathy, again, gastrointestinal, cardiac, genitourinary. Then you have got the diabetic amyotrophy. All three are over. Now we are going to multifocal neuropathies. This is not a peripheral neuropathy. This is more a focal types of multifocal neuropathy. Okay. What are the cranials usually involved in diabetes? This will be a very vivacious question. They may ask you what are the cranial neuropathies of diabetes. Like cranial nerve 3 without pupil involvement. Pupil is not affected. Cranial nerve 3 palsy, cranial nerve 6 palsy, sudden onset, ischemic. Sometimes they may have entrapment neuropathies, carpal tunnel syndrome, ulnar neuropathy, rarely mononeurotic multiplex of the vascular pattern also. Multiple nerves, single nerves are affected. So now the next question is clinical examination. What should I look for? Pinprick, temperature, 128 frequency vibration, and proprioception. What are the things you have to look for? Pinprick, temperature, vibration, proprioception. Motor, usually distal muscle wasting, intrinsic muscle wasting, and toe clawing. Can you tell me what is the reason for clawing in diabetes? Many of the diabetics, you see their feet, toes are clawed. Normally the toes are like that, and why? The tips of the toes, they have no sensation. Because they have no sensation, they don't have a grip where they are putting. In order to have grip, they'll try to claw it. That's the reason of clawing. The reason for clawing is the loss of sensation of the tips of the ball of the toe. Sensations are not lost. They do not know where they are putting their feet. In order to grab the ground correctly, they put the clawing occurs. So that's the cause of the clawing, toe clawing. If a patient has got toe clawing when he walks, immediately test the sensation. Sensations will be lost. Okay? Reflexes. Ankle reflexes lost early, knee reflex will be later. Autonomic, orthostatic blood pressure, hypotension, heart rate variability, skin changes, foot examination, and trophic ulcers and gangrene. If you do not examine the foot of a patient, you will not get the blessings of the Lord. Why? Because foot examination is so important. But what are the things I examine in the foot? One, the sensations. Two, the muscle weakness. Three, the circulation. And four, trophic changes. Foot examination is an art. It's not like that just seeing the foot. Foot is like, the blessing. For you to get the blessing, touching the patient's foot is the best blessing you can get. And the best blessing he can also receive. Because you identify. What are the blood vessels you palpate? Pedis and posterior tibial, anterior, posterior tibial, anterior tibial. Posterior tibial, where do you feel the posterior tibial?
Behind the malleolus.
Behind the?
Malleolus. Medial malleolus.
Medial malleolus. Okay. Medial, just hook the medial malleolus, then you have the posterior tibial. And also dorsalis pedis, where do you feel? Between the head of the first and the second metatarsal. Between the base of the first and second metatarsal. Metatarsal is like that. That is the head. This is the base. Base of the first and second metatarsal. You have to feel for the dorsalis pedis. So when I look at the foot, have glove yourself and then touch, feel the pulses. Then look for the sensations. 10 gram filament test. You have seen the 10 gram filament? You have the 10 gram filament? You never seen. How to test the sensation in the foot. At the end of this, I will show you. So 10 gram microfilament will be there. Only you have to use, and there are specific areas where you are supposed to touch it. Not everywhere, you can't touch. So there is a specific way you can touch it, and that is for the pinprick and the sensation touch, and then temperature, vibration, reflexes you have to see, ankle and knee reflex, and of course the autonomic changes. What do you look for on the skin of the foot for any trophic changes, calluses, ulcers, gangrene, all these things will be there. Okay, so investigations. What are the investigations? HbA1c, fasting postprandial blood glucose, B12 to eliminate the B12 deficiency neuropathy, renal function to see the CKD neuropathy, thyroid to see the entrapment neuropathy. Then you do electrophysiology, DSPN, axonal sensory motor neuropathy. It affects the axons. The axon has got this axon is the lengthy tube, and it has got a covering there. The covering is called the myelin. So this is a axonal degeneration and not myelin degeneration. Something like electric wire, there will be copper wire inside. That is the axon, outer plastic cover will be there. That is the myelin. So here DSPN is the axonal neuropathy, and then whenever axonal neuropathy is there, the amplitude is reduced, conduction may be normal. Then special test, skin biopsy for small fiber neuropathy, autonomic function test, nerve biopsy not required regularly. Differential diagnosis in diabetes. That's an exam trap. Not all neuropathies are diabetes. So CIDP. What is CIDP? Last time I told you. CIDP. Chronic inflammatory inflammatory demyelinating polyneuropathy. Chronic inflammatory demyelinating polyneuropathy. It is classically demyelination, whereas here it is axonal damage. Demyelination neuropathy is proximal, and usually it is not. It's a demyelinating disease. Nerve conduction studies, the conduction is reduced because of the demyelination. Proximal weakness, demyelinating, NCS, conduction reduced. B12 deficiency, there will be sensory ataxia, combined degeneration may be there, subacute combined degeneration, corticospinal and pyramid, and the posterior columns are involved. Anemia, macrocytic anemia may be there. Alcoholic neuropathy, history of alcoholism. Vasculitic neuropathy, asymmetric and painful neuropathy. Uremic neuropathy, advanced CKD. So you have differential diagnosis of diabetic neuropathy or CIDP, B12, axonal, vasculitic, uremic. CIDP is proximal, usually sensory neuropathy, less of muscle weakness, that is distal. Only in the diabetic amyotrophy, it will be proximal. CIDP is usually painless, whereas this diabetic neuropathy proximal weakness is painful. If I do in diabetes, the nerve conduction is not lost, it is normal, only amplitude is reduced because axon involvement. Here it is the myelin involvement, there will be conduction will be reduced, amplitude may or may not be absent. B12 deficiency, sensory ataxia and anemia will be there, alcoholic neuropathy, vasculitic neuropathy, and uremic neuropathy. The most important part of the story is how do I manage diabetic neuropathy. So you must know, yeah, you know, B12 injection, not like that, because what B12 will do for diabetic neuropathy. So whenever you go to a practitioner, general practitioners, diabetes person will go and complain of tingling and numbness. He will prescribe B12 tablets or B12 injection. Neurobion you take injection, or you give some methylcobalamin in tablets. You will give whatever. They are not going to help because it is not due to deficiency of B12. Unfortunately, deficiency of B12 is not the cause. So treating them with the vitamins, particularly B12 or B6 or B1, is not going to be helpful. Any diabetic neuropathy prescription, you see, they will put only B1, B6, B12 combination, injections, tablets like that. No, that's not the management. So what is the management? One, the disease management. Two, the neuropathic management. Disease management is glycemic control, most important. It prevents progression. It may not reverse the changes, but it prevents the progression. Keep the HbA1c to around 6 and not that. So the tight glycemic control will definitely help to arrest the progression and some improvement. So neuropathic pain control, duloxetine, pregabalin, gabapentin are the three drugs which are available. Duloxetine, pregabalin, or gabapentin can be used. These are the first line drugs. Second line drugs, if they're not controlled by that, then you can use tricyclics. Particularly, be cautious in the elderly and cardiac patients. Amitriptyline can be used as a second line drug for neuropathic pain. Avoid chronic NSAIDs. That means don't prescribe them some diclofenac or indomethacin because of the pain. This is NSAIDs are not going to really helpful. And then opioids also. So how do I manage? Tight glycemic control is number one. Second thing is duloxetine, pregabalin, gabapentin, not B12, B6, B1. Okay. How do I manage autonomic neuropathy? postural hypotension, good amount of fluid intake, fludrocortisone, tablets are available, medodrine also can be used. Gastric motility, dietary modifications, small quantities of frequent meals, and prokinetics can be helpful, particularly the type of drugs, that you have dysmotility disorder drugs are there, you can use. If there is erectile dysfunction, you can use phosphodiesterase inhibitors, 5 inhibitors. You can use like, your PDE5 inhibitors, Viagra, and those things. Then the foot care is very important. Daily foot inspection. If you don't examine the foot, no blessings from the patient. Proper footwear, careless care, early treatment of ulcers. And patient must be taught to inspect the foot daily. They must keep the foot as clean as the face. You see anyone? Face they will clean, apply powder 4 times a day and all that. With soap and water they will wash. But nobody sees the under surface of the foot. Any patient, take 100 people, face may be clean. The under surface of foot is worst because they don't inspect the foot. And there are special mirrors available. So a mirror will be like this, and there will be a long handle will be there. So this long handle mirror, they can put below their foot and then not see the under surface. In order to examine the under surface, they cannot look at the under surface. How can you look at the under surface of the foot, particularly with the joints and all frozen? You can't tilt and see. There will be a long handle mirror. That mirror you put under the foot and see in the mirror. How this one? Every day they have to examine, particularly because there is no sensation. The prognosis, slowly progressive, may improve, pain may improve, numbness will persist. Autonomic neuropathy worsens means prognosis is bad. Major causes of amputation are peripheral arterial disease and diabetic peripheral neuropathy. If you know that there are amputations occurring, non-traumatic amputations, that means not due to accidents or trauma. If we exclude the non-traumatic amputations, diabetes is the leading cause of amputation of the lower limb. It is the leading cause of amputation of lower limb after excluding the traumatic amputations. This is the leading cause of non-traumatic amputations. And also, one side amputated, there is a 50% chance of other limb getting amputated in the next 1 year. So if one person loses one limb, let's say in this year, due to diabetes, next year he will not have the other foot also, 50% of the people. That is the severity of the neuropathy here. So how do I manage? Management of diabetic peripheral neuropathy. So must be approached in 2 distinct tiers. One is the pathogenetic treatment. That means altering the course of the disease, and symptomatic treatment. Giving pregabalin or gabapentin or duloxetine is not going to change the disease. It is only going to give a temporary symptomatic relief. But pathogenic treatment for the cause, controlling the A1C, is very important. Now the foundation, pathogenic treatment, the only way to slow or halt the progression of TPN is through metabolic control and lifestyle modification, glycemic control, type 1 DM, strict control. It significantly reduces risk of developing diabetic polyneuropathy. Type 2 diabetes control is essential, but the effect on preventing DPN is less robust than in type 1, suggesting other factors like dyslipidemia, hypertension may play a role. Avoid insulin neuritis. There is one term called the insulin neuritis. This is treatment-induced neuropathy. Rapid correction of chronic hyperglycemia can trigger acute, painful, and reversible small fiber neuropathy. That is called the insulin neuritis. A small short note sometimes you may get. Describe insulin neuritis. Insulin neuritis is treatment-induced neuropathy due to sudden correction of hyperglycemia, chronic hyperglycemia, suddenly brought down, can result in acute, painful, reversible small fiber neuropathy. Lifestyle factors, aggressive management of the metabolic syndrome, particularly blood pressure, statin therapy for dyslipidemia, smoking cessation are very important. Symptomatic management of neuropathic pain, we have already known We have got the gabapentinoids, out of which pregabalin, gabapentin. How do they act? Mechanism of action. Alpha and delta subunit of voltage-gated calcium channels are blocked. They bind to the alpha subunit of voltage-gated channels and delta subunits. So these are the first line treatment. Pregabalin has a linear pharmacokinetics, easier to titrate than gabapentin. My preference is to use pregabalin rather than gabapentin. Watch for peripheral edema and sedation. These are the two side effects. The moment you put him on gabapentin, they will have some sort of nausea, vomiting like thing, head vertigo like thing. They may complain. Peripheral edema may be there. They may feel drowsy, particularly drowsiness and sedation, an important side effect of gabapentin and pregabalin. Duloxetine, venlafaxine are the two other SNRIs, selective noradrenaline reuptake inhibitors. Duloxetine and then venlafaxine inhibit the reuptake of serotonin, noradrenaline dual inhibitors. Serotonin, norepinephrine receptors inhibitors are there, inhibit the reuptake inhibitor, serotonin and norepinephrine, SN, serotonin noradrenaline reuptake inhibitors. First line treatment, excellent for patients with comorbid depression and anxiety. If they have depression also associated, better to put them on duloxetine or venlafaxine. Avoid in severe renal or hepatic impairment. Tricyclic antidepressants, amitriptyline, nortriptyline are the drugs, multiple the mechanisms of action, block sodium channels, inhibit the monoamino oxidase reuptake. These are MAO inhibitors, highly effective, but limited by the anticholinergic side effects, dry mouth, urinary retention. Avoid in the elderly or those with cardiac conduction block. That is the caution. Elderly and cardiac conduction block, you should not use. Sodium channel blockers, carbamazepine, oxycarbazepine, they stabilize the neural membranes, often used as second line or if the pain is electrical and shooting in nature. So what are the drugs I have? I have got 4 groups of drugs, gabapentinoids, which are the first line, then SNRIs, duloxetine and venlafaxine, then I have tricyclics, caution is in elderly people and cardiac conduction defects, and sodium channel blockers, which are the oxycarbazepine and carbamazepine. They can be used as second line drugs. And strategy for stepwise therapy of AAN and ADA guidelines, American Association of Neurology and American Association of Diabetics guidelines, start with monotherapy, usually gabapentin or pregabalin or an SNRI, duloxetine. Assess and titrate 2 to 4 weeks at the therapeutic dose before declaring failure. You should not start today and tomorrow, sir, my pain is not improving. No. It will take at least 4 weeks. So only after 4 weeks, we'll come to know whether it is working or not. Combination therapy, if monotherapy at maximum dose is insufficient, combine agents with different mechanisms like pregabalin and duloxetine or pregabalin and carbamazepine like that. Topical agents, capsaicin 8% patches or lidocaine plasters for localized hotspots of pain to minimize systemic side effects. And diabetic foot care, the neuropathic foot. Neuropathy leads to insensate foot, which is a precursor of ulcers. Charcot's neuroarthropathy, screening annual 10 milligram filament testing and vibration sense. That's very important. All of you must carry 10 milligram filaments and vibration fork also. Education, daily foot inspection, never walk barefoot, proper footwear. Okay? Charcot's foot. So if a diabetic patient presents with red, hot, swollen foot without an open wound, it is a Charcot neuropathy until proven otherwise. Immediate offloading is mandatory to prevent the permanent deformity. What is Charcot foot? Charcot foot is if a diabetic patient present with a red, hot, swollen foot. There is no ulcer, there is no infection, there is no wound, but the foot is hot, red, and swollen. It is Charcot's neuroarthropathy, and it should be immediately offloading of that particular area by proper footwear and foot care has to be done. I used to have one patient of type 1 diabetes. He is around 30-year-old. One day what he did was he went to a temple near Tamil Nadu, Tirthani place. There he walked barefoot in May. In May in Tamil Nadu it will be quite hot, and walked barefoot onto the hill, and then all the hill he was not having any pain. That's why he didn't know what will happen. And then by the time he came home, the huge blisters are formed. Next day he came to me, severe ulceration of the sole of the foot because of the heat injury. Severe heat injury, walked barefoot, no sensation. So he almost walked on fire, then came. So it took around 3 months for us to nurse the wounds. Ultimately he died because of the peripheral neuropathy was so severe. So very important that they should not walk barefoot at all. Okay. Online answers. Most common neuropathies in diabetes are distal symmetric polyneuropathy, painful proximal weakness, consider diabetic amyotrophy, most dangerous complication, cardiac autonomic neuropathy. Best treatment is tight glycemic control, symptomatic treatment, pregabalin, and then the gabapentin. Taking pearls, burning fluid with normal NCS, small fiber diabetic neuropathy. Proximal muscular weakness, diabetic neuropathy. Pupil sparing cranial nerve paralysis, distal symmetric polyneuropathy, that is the loss of ankle reflex, distal sensory polyneuropathy. Now we look at some questions. You see the questions. Now you see the question and read the question.
Distribution and absent angle reflex, motor power is normal.
What is that? What does the history suggest?
Distal symmetric diabetic neuropathy.
12-year diabetes, positive sensory symptom is there, burning pain, and it is worse at night also. Okay, there is a reduced pinprick and also vibration, and glove and stocking in its distribution. Ankle reflexes are lost. Means what? Motor power is preserved. What type of neuropathy is that? CIDP, chronic inflammatory demyelinating polyneuropathy, A. B, small fiber neuropathy, D. C, distal symmetric diabetic polyneuropathy, D is DSDN, and then the diabetic amyotrophy. Which is the answer? Huh? C, distal symmetric diabetic polyneuropathy. Why? Motor power is impaired, ankle jerk is lost, vibration is lost, positive sensory symptoms are there, burning feet are there, both feet are affected, symmetric involvement. Okay, the correct answer is C. Explanation. Symmetric, length dependent sensory loss, length is longer the axon, then it is affected. Absent ankle reflex, long-standing diabetes, a classical distal symmetric polyneuropathy. So let us see the next question. Severe burning pain only. Vibration and ankle are preserved. That is small fiber neuropathy. Whereas large fiber neuropathy, you will have the proprioception vibration will be there. Nerve conduction studies will be normal in these patients. And it is not large fiber, myelinated fibers, not anterior horn cell. Anterior horn cell, where is the need for pain and burning and all that? Anterior horn cell means you should have some muscle weakness. Dorsal columns means you will have reflex and ankle reflex should not be preserved or should be affected. So the answer is small unmyelinated fibers. Okay, that's the correct answer. Next, look at the explanation. Painful neuropathy with normal NCS, preserved reflexes, indicates small fiber neuropathy, commonly seen in early diabetes. Now look at this question. These are all from the MRCP questions. Question bank. I teach MRCP and I'm examiner. These are pulled out from the MRCP question bank. What are the clinical features there? Dizziness and standing, postural hypotension. Okay, 140, 90, 170, more than 10 mm difference is there. Postural hypotension. Within 2 minutes, he is getting that. And heart rate does not increase. There is resting. Autonomic neuropathy, heart rate doesn't increase. Heart rate is already fixed. Usually tachycardia may be there. So looks like a diabetic Autonomic neuropathy, DAN. Underlying mechanism of dysfunction? Is it sympathetic postganglionic fiber or parasympathetic vagal fibers, baroreceptors, neuromuscular junction? Which is FA? It is very clear it is diabetic autonomic neuropathy. We are asking where is the pathology? Sympathetic postganglionic fibers. Parasympathetic will not produce any postal hypotension. Baroreceptor effect is not that. Neuromuscular junction will not be like that. So the answer will be A. Failure of the sympathetic vasoconstriction. How we are not getting orthostatic hypotension, you and me? The moment I stand, there is sympathetic vasoconstriction. And does it allow the blood to pool here and maintain the blood pressure? In diabetics, what happens? Sympathetic vascular tone is affected. They are not getting the sympathetic vasoconstriction. There will be pooling of the blood in the lower limbs once he stands, and that produces autonomic neuropathy. That is the postural hypotension. Okay. Question number 4. Which of the following diabetic neuropathy is associated with the worst prognosis and increased mortality? Cardiac autonomic neuropathy. Cranial mononeuropathy is not going to die. Diabetic amyotrophy, painful muscle will be there, but no death. Symmetric polyneuropathy is long-standing. Cardiac autonomic neuropathy is the most dangerous one, and that is worst prognosis. Correct answer is D. Next. What is having? Painful, proximal, asymmetric. Only one side. And weakness. Okay, painful neuropathy, proximal muscle weakness, and weight loss, 55-year-old diabetic. Asymmetric proximal weakness with reduced knee jerk. Okay, is it CIDP? Is it? Okay. Diabetic amyotrophy. Lumbar disc prolapse. It is not going to produce, only one proximal muscle weakness. It will be very different. CIDP is proximal, but also we will not get generally. It's a myelin problem more. Here, motor neuron disease will not present like that. Only diabetic amyotrophy is the reason. The idea is diabetic amyotrophy, proximal muscle, painful proximal muscle. Motor neuron disease, no need to have any pain there. Okay, correct answer is C. Then you have got the 6th question. The earliest pathological event in diabetic distal symmetric polyneuropathy is distal symmetric polyneuropathy. Is it a motor neuron? No. Is it myneural junction? No. Is it the myelin sheath? Not. It is an axonal degeneration. The answer is axonal degeneration. A diabetic patient is primarily axonal. A diabetic patient presents with acute onset of diplopia. Okay, examination shows ptosis, ophthalmoplegia, and pupil sparing. Diplopia because of the third nerve involvement. Pupil sparing is there. There is ptosis also is there. This is a third nerve involvement, which is a cranial neuropathy of diabetes origin. Which nerve is most likely involved? Trochlear, abducens, oculomotor, optic. Obviously, answer you know. What is the answer? That is the C is the answer. Okay. Now, question number 8. Which nerve? Read that. Diabetic distal symmetric polyneuropathy. The classical 70% of cases are like that. What will be the NC study? Nerve conduction. Markedly slowed conduction velocity. No, that occurs in myelin degeneration. There will be conduction block. That's also not correct. Reduced CAMP and SNAP amplitude. Conduction is normal. Okay. So, answer must be C. Normal amplitudes will not be there. Okay. Should know that. Question number 9. A diabetic patient had progressive proximal and distal. Both proximal and distal are involved. Areflexia is there acute. So in 8 weeks he got. NCS showed demyelinating features. Demyelinating features means conduction is lost, amplitude is maybe spare. So what will be the answer? Diabetic polyneuropathy or CADP or diabetic amyotrophy or alcoholic. Diabetic polyneuropathy, NCS features will not be demyelinating. So first is not there. Diabetic amyotrophy, only proximal will be there, distal will not be involved. It's only the both proximal and distal are affected. So it is chronic, inflammatory, demyelinating polyneuropathy must be the answer. It's not alcoholic because no history of alcohol is given. So the answer will be very clear. Okay. Demyelinating pattern with proximal weakness such as CADS, that's over. The most common disease modifying intervention is tight glycemic control. The others are symptomatic. Steroids are contraindicated. Okay, pregabalin, amitriptyline, second line. Pregabalin, first line, symptomatic. Tight glycemic control is the treatment. Okay, now 11. See that glycemic control prevents progression, that's okay. Loss of pain sensation and diabetic neuropathy most commonly leads to foot ulcers. Cellulitis, rare, can occur. Charcot joints, the neuropathic joints. Muscle cramps, not correct. Foot ulcer must be the answer. That's okay. Now, 12. Burning feet, normal reflexes, normal NCS, diabetic patient. Burning feet, small fiber neuropathy. Correct. That's all. So with this, we are ending our class.